Okay, in this video, I'm going to be talking about how to read an EKG systematically. So when you present to a cardiology attending an EKG, you have to read it the same way every time. I'm just going to be talking about the features that are important in the order that they are read. So the first thing you do is read the rate, then the rhythm, then the QRS axis, then the intervals, the complexes, the chambers, and then any signs of ischemia or infarction. And most importantly, you compare with the prior EKG, as every patient is different. So let's talk about rate. So the first thing you determine is it regular or irregular. And the way you determine this is you look at the RR interval, so the difference, the length and time between each R wave in the QRS complex from cycle to cycle. If it's the same, then it's regular. If it's different, then it's irregular. And this is actually a rhythm characteristic, so it, I'm just telling you this so that you can calculate the rate. So for if it's a regular rhythm, you divide 300 by the number of large boxes between each QRS, and that gives you the heart rate. If it's an irregular rhythm, so the RR interval is variable, then you look at lead 2 and then you count the total QRS on the 10-second strip and multiply it by 6, and that equals your rate. So if it's normal, then it's 60 to 100. If it's less than 60, it's bradycardic. If it's greater than 100, then it's tachycardic. Okay, next thing. So rhythm. So is it regular or irregular? And is it sinus or non-sinus? So what is the definition of a sinus rhythm? So there has to be a P wave before every QRS and a QRS following every P. Is the rate between 60 and 100? And is there a P wave upright in leads 1 and 2 and inverted in AVR? If yes to all three questions, this is normal sinus rhythm. If not, it's non-sinus rhythm. And if it's non-sinus rhythm, you can determine the atrial rate. So 100 to 180 is sinus tachycardia. 140 to 220 is the atrial tachycardia, AVNRT or AVRT. 260 to 320 is atrial flutter. So to calculate this, you look at the P to P intervals and you can calculate the atrial rate from that. The next thing is the axis. So this is already stated. This is the P wave axis referring to that. So for that to be normal, then the P wave has to be upright in leads 1 and 2 and inverted in AVR. And the next thing is the QRS morphology. So is it wide or not narrow? So if it's narrow, then the QRS width is less than 3 boxes. And if so, the rhythm is of a supraventricular origin. If the QRS complex is greater than 120 milliseconds, then it's aberrant supraventricular conduction or ventricular origin. Next thing you want to do is look at the P wave to QRS complex ratio. So if it's not 1-to-1 ratio, you determine the number if P is greater than QRS or QRS greater than P. So if there's more P waves than QRS, then this is the AV block. If there's more QRS than P, then this is the AV node, his hypercondry or ventricular rhythm. So if the P precedes every QRS, you evaluate the PR interval. If the P is after the QRS, evaluate the RP interval, and then determine if the interval is fixed or variable. So the different types of PR interval abnormalities are AV block first degree, second degree, and third degree. So first degree is the PR interval is greater than 200 milliseconds, but there's no QRS drop. Second degree, so you have Mobitz type 1 wanky back, which is the PR interval progressively lengthens until there's a drop in the QRS. Then you have Mobitz type 2, which is a sudden drop in the QRS without PR lengthening. And then you also have third degree block, which is a dissociation of P and QRS. So the next thing you want to determine is the axis. So we talked about rate, rhythm, and axis. Now we're going to talk about QRS axis. So to determine the axis and make it simple, you will use two reference points. So one is lead 1 and the other is lead AVF. So let's say your left hand is lead 1 and the right hand AVF. So if the lead is positive, your thumb is pointed upwards. If two thumbs are upwards, it is normal axis. If either is pointed upwards and the other downwards, whichever lead is upwards is the axis that it's deviating towards. So in medical terminology, the scientific way of doing this is finding the most isoelectric lead, and the lead that is perpendicular to that lead is the axis that it's deviating towards. No one actually uses this method. So let's say that the lead 1 is positive and lead AVF is positive. then you have normal axis. Now lead 1 is positive and lead AVF is negative. Your left hand will be pointed upwards and your right hand downwards. Then your left, it's a leftward axis. Now let's say lead AVF is positive and lead 1 is negative. Then this is a rightward axis. And when they're both downwards, that means this is an extreme or northwest axis. And this is in very rare cases. So if we think about why this is the case, so on an EKG strip, a positive amplitude means that the electrical depolarization is headed towards that lead. So conditions that make the chamber to be increased or muscular hypertrophy, then the conduction will be increased in that direction. And if this is either in the left or right side, it will cause deviation towards that axis. So let's talk about clockwise or counterclockwise rotation. So this is called R wave progression. So the R wave typically becomes greater than the S wave at around V3 to V4. If this happens earlier, this is called early R wave progression or counterclockwise rotation. The same analogy described earlier applies. The conditions that cause this are like right ventricular hypertrophy. And if the R wave becomes greater than the S wave later than V3 or V4, then this is late R wave progression due to left ventricular hypertrophy or similar causes. Now let's talk about low voltage. So this is anything that causes the depolarization signals to not be transmitted through to the leads on the skin. Think about things that can get in the way like obesity, pericardial effusion, pneumothorax, COPD, pulmonary embolism, restrictive or infiltrative cardiomyopathy due to amyloidosis, severe hypothyroidism, or anasarca, otherwise known as ascites. So now we talked about QRS axis. The next thing you want to determine is complexes and intervals. So all of the waves and intervals have a specific length and height that is in the normal range for duration and amplitude respectively. So the P wave is normally less than 120 milliseconds. The voltage would be greater than or equal to 0.1 millivolts in 1. You could also calculate the area, which is half of the duration times the voltage in 2. And if it's less than or equal to 4, it's normal. Another thing is the PR interval is the time between the P wave and the R wave. This is usually 140 to 200 milliseconds. This changes with rate, so it's shorter at faster intervals, or shorter at faster rates and longer at lower rates. Another thing is a QRS interval. So this is normal is 60 to 110. 100 to 120 could be signs of incomplete bundle branch block or intraventricular conduction delay. QRS greater than 120 milliseconds is due to bundle branch block, ventricular activation, hyperkalemia, any channel poisoning, aberrancy, or hypothermia. And the other things I'm going to talk about is the fascicular blocks. So there's left anterior fascicular block, which is a left axis deviation. The QRS will be less than 120. There will be a QR wave in 1, AVL and RS wave in 2, 3, and AVF. This is common and non-specific for any condition. Then we have a left posterior fascicular block in which there's right axis deviation, QRS less than 120 and RS wave in 1, AVL and QR in 2, 3, and AVF. This is rare in isolation, usually with a right bundle branch block. So right bundle branch block is a QRS greater than 120. There's a RSR wave in V1 and V2 and a wide QRS in V6. The S will be greater than R duration in 1 and V6, and the causes are infection due to myocarditis, infarction, increased right ventricular pressure due to pulmonary embolism or cor pulmonale. A bifascicular block is right bundle branch block plus left anterior fascicular block or left posterior fascicular block. Then we have a left bundle branch block in which the QRS is greater than 120 or 3 boxes. There will be wide negative QS wave in V1 and a wide tall R wave in 1, AVL, V5, and V6. The causes are primarily due to, or could be due to primarily dilated cardiomyopathy, either due to ischemia, infarction, infection, valvular disorders, or infiltrative disease. Then we talk about the ST segment, which is normally isoelectric. And then we have a T wave, which is usually asymmetric and in the same direction as the QRS, should have the smooth contours. Then we have the U wave, which occurs in the same direction as the T wave. This is rate dependent. The differential for this is bradycardia, hypokalemia, hypomagnesemia, hypocalcemia, or hypothermia. Then we have the QT interval, in which there's ventricular depolarization and repolarization. A normal QT interval is less than 440 milliseconds, greater than 460, normal is less than 440 and less than 460 respectively in females and males. Let me just double check that. Yeah, 440 in less than 440 in males and less than 460 in females. Then we're going to talk about chamber enlargement. Left ventricular hypertrophy, the Sokolow-Lyon criteria states that if there's a S in V1 plus the R in V5 or V6, and if both of those are summed to be greater than 35 millimeters, or in an R wave in AVL that's greater than 11 millimeters, greater than or equal to 11 millimeters, then you have LVH. The Cornell criteria states that if there's a S in V3 plus R in AVL greater than 28 millimeters in men and greater than 20 millimeters in female, then you have LVH. So for reference, each small box in the EKG is 1 millimeters. So then we have right ventricular hypertrophy, in which the R is greater than the S wave, or R is greater than or equal to 7 millimeters in V1, and the S is greater than or equal to 7 millimeters in V5 or V6. Basically, in the leads that are on the right side. And then we have left anterior enlargement, in which the P wave duration is greater than or equal to 120 milliseconds, or widely notched P wave greater than 40 milliseconds, and or a negative component in P in V1 greater than 1 millimeters wide and deep. And then we have right atrial enlargement, in which the P wave height is greater than 2.5 millimeters and 2 initial positive P wave in V1 and V2 greater than or equal to 1.5 millimeters. Then we talk about ST segment and T wave changes. So I'm gonna stop this here. I'm gonna make a part 2. Okay, this is EKG interpretation part 2. You need to watch that first video, but I'm just gonna continue on where I left off. So we're gonna talk about ST segment and T wave changes. So to make it simple, when there is a ST segment depression and T wave inversion, this is a sign that there is reversible ischemia or inadequate perfusion of the myocardium. When there is ST segment elevation, this means that there's transmural ischemia due to a ST segment elevation myocardial infarction, or otherwise known as STEMI. This happens within 10 to 15 minutes of a heart attack. To think about what's happening, the transmural ischemia means all the layers of the heart are ischemic and not conducting electrical signal. On a lead to the respective part of the heart, the baseline amplitude will be decreased. However, when passing currents from other parts of the heart flow through during diastole, it shows up as a positive inflection on the lead. Then we have T-wave abnormalities, which hyperacute symmetric T-waves can be found within minutes of ischemia, followed by T-wave inversions, which is greater than or equal to 1 millimeters in 2 contiguous leads. Contiguous meaning corresponding to the same region of the heart. T-wave inversion is normal only in AVR, V1, or 3. Isolated T-wave inversion in AVL may indicate mid left anterior descending lesion or inferior MI. Then we have ST segment depression, which suggests subendocardial injury. So greater than 0.5 millimeters below the baseline, measured 80 milliseconds after the J point in 2 contiguous leads. If they're downsloping or horizontal, this is ominous, which meaning that there might be a sign of impending myocardial infarction. You should always look for the ST elevation to rule out reciprocal ST depression. What that means is, so in a perpendicular lead, you look at if there's ST segment depression, and if that is the case, then that is characteristic for myocardial infarction. And ST depression in V1 to V3 can be posterior MI. Then we have ST elevation, which suggests transmural ischemia. So greater than 1 millimeters in leads except for leads V2 to V3 is significant enough for ST elevation. Greater than or equal to 2 millimeters in males greater than 40 years old for leads V2 to V3, or greater than or equal to 2.5 millimeters in males less than 50 years old, or greater than or equal to 1.5 millimeters in females in leads V2 to V3 are significant for ST elevation. Another thing is using the PR segment measured at the J point for reference is a good point of reference to compare the ST elevation to. And then for differential diagnosis of ST elevation, acute STEMI will show ST elevation in greater than or equal to 2 contiguous leads. LVH, there will be concave ST elevation in V1 to V3 with ST depression and T-wave inversion in 1 AVL or V5 to V6. And left bundle branch block will show concave ST elevation in V1 to V3, a discordant, which means going in a different direction with negative QRS in the preceding QRS. And then acute pericarditis, there will be diffuse ST elevation less than 5 millimeters elevation. PR depression amplitude of ST elevation to T-wave should be greater than 0.26, which is specific for acute pericarditis. We have prinzmetal angina or vasospasm, in which there is a transient ST elevation and coronary distribution, as in ST elevation. We have acute pulmonary embolism, in which there is ST elevation in inferior and anteroseptal leads, which mimics acute myocardial infarction, complete or incomplete right bundle branch block. Then we have stress-induced cardiomyopathy, in which there is diffuse ST elevation in precordial leads without reciprocal inferior ST depression. Then ST elevation followed by deep T-wave inversion. We have ventricular aneurysm, which there's a persistent ST elevation after MI, often with abnormal Q waves. We have early repolarization, which there's a J point elevation of greater than or equal to 1 millimeters in 2 contiguous leads. The amplitude of ST elevation to T-wave will be less than 0.25. And then you have Brugada syndrome, in which there's a RSR wave and downsloping ST elevation in V1 to V2. Male pattern of ST elevation will show 1 to 3 millimeters concave ST elevation, often highest in V2. Normal variant will be ST elevation in V3 to V5, T-wave inversion, short QT, or high QRS voltage. A cardioversion will show marked and transient ST elevation following direct cardioversion. So let's talk about the coronary distribution. So V1 to V2 are known as the anterior septal leads. V5 to V6 are the apical leads. 1 and AVL are the lateral leads. 2, 3, AVF are inferior leads. V7 to V9 are posterior leads. V4R is the right ventricular lead. AVR doesn't correspond to any lead. V1 through V6 are known as the precordial leads. And these all correspond to the different regions of the heart. So the Scarbosa criteria is to diagnose acute MI in those with left bundle branch block. And you will have a concordant ST elevation greater than 1 millimeters in any lead. So basically the QRS, you'll have a QRS, and then you'll have the ST elevation greater than 1 millimeters in any lead. You can also have a discordant ST elevation greater than 5 millimeters in any lead. That'll be this one right here. So you see the QRS wave goes down and then this goes up. Greater than 5 millimeters, that is a sign of the left bundle branch block. And then you can also have ST depression and greater than 1 millimeters in V1 to V3. You get 3 points here. So a Q wave is usually a marker of a scar. Pathologic Q waves must be deep, greater than 1 millimeters, 25% of height and of QRS, and 40 milliseconds long. This is more likely secondary to prior MI if the inverted T wave is in the same lead. A small septal Q is physiologic in V5, V6, 1 in AVL. Then we have something called a Wellham syndrome, which is a sign of a critical proximal left marginal or left anterior descending lesion, often pain-free without history of angina. This will show normal or slightly elevated troponin. Type A is 25% biphasic, which will show up and then downsloping T waves in V2 and V3. Type B is 75% symmetric, which will show a deeply inverted precordial T waves. Isoelectric or minimally elevated, less than 1 millimeter ST segment, no precordial Q waves. Now let's talk about the J point. So the J point is when the QRS transitions to the ST segment. On the differential for J point elevation is early repolarization pattern, in which there's a benign ST elevation in absence of chest pain, terminal QRS slur, or terminal QRS notch. It's suspicious if there's a family history of sudden cardiac arrest or early unexplained death. The workup, you should suspect channelopathy with history of unheralded syncope, basically any syncope without any reason, and could be suggestive of an arrhythmia. We have Brugada pattern, in which the syndrome is only if symptomatic. Autosomal dominant loss of SCN5A receptor in 10 to 30% of cases. There's men get it more than females, and it's common to have nocturnal cardiac arrest, presents with ventricular tachycardia or ventricular fibrillation or sudden cardiac death. This is what Brugada syndrome tends to look like. Then we have Osborne wave, in which there's a due to hypothermia, temperature less than 93 Fahrenheit. There will be an elevation of J point height proportional to the degree of hypothermia in 2 and V2 through V6. It's more dome shaped than epsilon wave. This is an Osborne wave right here. Then we have the epsilon wave, which is found in arrhythmogenic right ventricular cardiomyopathy due to ARVC, inherited, age 10 to 50, fibrofatty replacement of right ventricular myocardium, which leads to ventricular arrhythmias. There'll be more SP in V1, low frequency or positive terminal deflection in V1 to V3. Then we have different electrolyte abnormalities. So for hypokalemia, this will lead to a prolonged QT, ST depression, flattened T wave, prominent U wave, higher amplitude P wave, and prolonged PR interval. Hyperkalemia will show peaked symmetric T wave, and then it will progress to a flat P wave, progressing to a prolonged PR plus AV block, progressing to a widened QRS plus bundle branch block, and then it goes sinusoidal. And we have hypocalcemia, which is a prolonged QT and interval and then unchanged T wave. Then we have hypercalcemia, which is a shortened QT interval. And if it's severe, the T wave can merge with the QRS and mimic ST elevation. And so that is EKG interpretation part 2. Sorry if I couldn't explain everything in detail. You're going to have to look it up and dive into it more in depth. This is like just a brief overview of everything that you're supposed to do. So if you were to present the patient on an EKG, first you talk about the rate, the rhythm, then the QRS, any changes to the complexes and intervals, then the chamber enlargement, then ST segment and T wave changes, and then J point elevation syndromes and electrolyte abnormalities. You don't have to report everything, but whatever's significant in those criteria, you definitely present